Thank you all for joining. I'm Jenny Denai, Chief Mission Delivery Officer with Lung Cancer Initiative. And I'm excited to kick off our Navigator call today. I am really excited to introduce you to our new program manager for Screening Saves and really all things early detection at Lung Cancer Initiative. And that's want to introduce you to Macy McFarland. She's here on the call today, and you will be hearing from her a lot in the future. So welcome, Macy. And trying to think of a couple other just housekeeping. If you could put your name and your organization in the chat, and maybe even the city you're located in, so we can see where everybody's located, and if you wanted to get connected with anybody, you could. And let's see. Otherwise, I think that's it from me. So we will have our speakers today, and then we'll have time for question and answer at the end, and also discussion if you guys want to talk about anything in particular. I know smoking cessation has come up as a topic area, so we can always discuss that at the end or decide if we want to have that as a main topic for our next call. So we'll go ahead and get started today. We have, let's see, we have Kathy Wibberly, and we'll have Aimee Strong also from the Mid-Atlantic Telehealth Resource Center. And so we'll be talking about telehealth today. And I know several of you already are using telehealth in your screening programs. And so I'll be curious to hear about this resource along with you all, and see how we can use this, or see how you can use this in your practice. Kathy, if you're on, if you want to, hey, Kathy.
Hello, how are you?
Good. How are you?
Doing well.
Do you have slides you want to share?
I don't have slides. I think I was just going to talk a little bit about the resource centers in general. I can send you a set of slides that you can pass along, but I thought it would be easier just to
Okay,
kind of explain what we are and what we do and how we assist. So,
perfect. Thank you.
yeah. So I'm Kathy Wibberly. I'm director of the Mid-Atlantic Telehealth Resource Center. And for those of you who are not familiar with the telehealth resource centers, we are federally funded by HRSA. Prior to the pandemic,
Yeah,
the
that's
Telehealth
what I
Resource
had.
Center was under the Office for the Advancement of Telehealth, which was under the Office of Rural Health Policy at the federal
Forgot
level. Since the
what year.
pandemic, it's been moved under the
You
HRSA
started talking, it
administrator.
scared me.
Sorry, I'm hearing noises. Um, so we are now under the HRSA administrator, and the whole office is really there to support all efforts to expand telehealth and its use for rural but also underserved populations. So that is the focus. Our telehealth resource center is one of 12 regional resource centers. So we cover the regions between New Jersey from the north down to North Carolina, all the way over to Kentucky. So North Carolina is our southernmost state that we cover within our footprint. Our resource center is one of the 12 regional, as I mentioned, but there's also two national resource centers. So one of the nationals covers health policy or telehealth policy, and they are based in California. They're the Center for Connected Health Policy, and they are basically the largest database that you could ever find on all things telehealth in terms of policy, regulations, state and federal. They do issue briefs. So if you're interested in telehealth policy, if you're interested in understanding what's going on, whether it's North Carolina, nationally, Medicare, Medicaid, sign up for their newsletter because they give you all sorts of updates on what's happening at the state level, at the federal level, and it's a great place to just search for anything. The other national center is the uh, Technology Assessment Resource Center, and they're really looking at helping us as regional resource centers, as well as you all, to assess what technologies are out there, what are emerging technologies, help you identify things that might meet requirements. So if you're saying, I really need a technology to do X, Y, and Z, I'm in a very rural population with very low bandwidth. I have like 10 vendors that are knocking at my door. How do I assess like what I'm looking for? They can absolutely help you with your requirements. Now, as federally funded centers, we cannot endorse or recommend particular vendors, but we can definitely help you figure out what your needs are and what the specifications are, and what you really need in order to access the vendor. So back to the Mid-Atlantic. The regional telehealth resource centers are here to provide everything in terms of technical assistance and training. So if you have any interest in a telehealth program using telehealth, and we define telehealth really broadly. So everything from your traditional video conference to remote monitoring, wearable devices, um, text-based devices, AI generated kind of interactions that are health related, mobile apps. So all of those things are within our wheelhouse, and we work with you on everything from very simple questions like, can I get reimbursed by doing this? Or very complicated questions like, we have 200 patients in this particular setting. We are really needing to figure out how to get them broadband so that they can connect to healthcare services and help them get trained. Um, we work with digital navigators who are, working in the space of helping patients connect to their telehealth visits. We can point you to various trainings if we don't do them ourselves. And our services are, I would say, like 98% free of charge. So please like reach out if you have questions, if you have concerns, if you have everything from the simple email question to the huge, like, I need help just starting and setting things up and getting things off the ground. The way that the Mid-Atlantic Resource Center works is that it's myself, I am half-time, and then I have a full-time outreach coordinator, but I also have a network of what we call consultative service partners. So these are folks that we have on retainer that have large areas of specialty. So it could be areas that are related to technology, to school-based health programs, to digital navigation, to emergency preparedness, to stroke and remote patient monitoring. So all of those things are in our wheelhouse. And so what happens is if you send me an email or do go online and submit a technical assistance request, I would say about 70% of the time I will field those because they're oftentimes like a question that I can answer or a quick meeting or two meetings where we sit down, we talk through your programs, we brainstorm ideas, and then we just like do some back and forth along the way. But if you're saying like, I am working with a network of providers who are wanting to do uh, telehealth for pulmonary screening, and we are starting from scratch. We have nothing set up yet. We need policies, procedures, program models. I will connect you with either someone where I am based at UVA or someone from my team that is really familiar with that service line. And then we just pay them to work with you for that. So that's kind of a big picture scope of where we are. I am very, very invested in rural communities because my background is both in mental health. I'm a psychologist by training, but also a state office of rural health director for Virginia for about 7 years. And so I am like very, very invested in being able to bring access to care for rural. And so we recently did an event, a virtual event called Bridging Rural Communities. It was focused on the Appalachian region and really showcasing models of programs that have worked for that population. And one of those was by Amy, who I hopefully is on now, um, who was able to really share about a pulmonary care program that has been working really well for the Appalachian region. And so that's kind of a really quick, in a nutshell, scope of where we are, the types of things that we provide assistance with. And our website, I will put in the chat, which is matrc.org. um, has a lot of best practices around everything from, helping patients with broadband and access all the way to telehealth best practices related to etiquette and related to policy. So please use the website resources. We have a chat bot at the bottom right-hand corner that you can test out and use to ask questions. We've tried to confine its answers to within the website. That's one of the unique things about our chat bot. So it should not hallucinate, but we also keep a tabs on what the responses are, and we can correct things if there is a mistake. So that is our URL in the chat right there. And happy to entertain any questions.
Thank you, Kathy. This is a great resource. I don't think Amy's on yet, but I wanted to see if anybody had any questions for Kathy so far. And I know there are a few on here that definitely have telemedicine programs for screening. So I don't know if there's anyone who even wants to share how they're using it, or if you have specific questions for Kathy.
I don't have any specific questions, Jenny. First of all, Kathy, thank you. We do have a full telehealth program at Duke
Yeah.
to see patients for screening, both for lung cancer as well as for lung nodules. I'm just curious. I had no idea you were even a resource, but do you anticipate that you're going to be around and that we're going to be able to continue doing this, given the current administration's view on health, shall we
Yes.
say?
That's a great question. So we were a little nervous there because this was our year of competitive renewal, and we got our notice of award. So we are, in theory, funded for the next 4 years, and we've been around since 2011. So this is a long-term program. I know Tom Engels, who's the administrator for HRSA and was in the previous Trump administration, is a huge fan of telehealth. So fingers crossed that we'll be around for a while.
Oh, great. Thank you. This has been
Yeah, thanks for the
wonderful. It's nice
question.
to know you're there.
Well, and Debbie, stay on for a minute too. Debbie and Kathy, I know Kathy, you talked about some of the legislative things, but is it how is reimbursement for this? Is that harder to get? And Debbie, you might even know more specifically, but I know there were some things coming along saying that insurance wasn't going to cover telemedicine visits anymore. I don't know if that's the thing, but
Yeah, I can give you kind of the landscape, and I'm not sure where Amy is. I haven't actually talked to her in a while. So, um, but the landscape for telehealth is actually really good right now for both private payers and for Medicaid, for most state Medicaid programs. The big question mark is Medicare. And if any of you have been following the saga of Medicare, um, ever since the pandemic, it's been under the PHE waivers, and they keep kicking the can down the road. So instead of ending when the public health emergency was declared over, Congress kicked the can down the road and said, well, we'll extend it for blah, 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 blah. That extension then got connected to the continuing resolution for the budget bill, and it got kicked down the can. Kicked the can got kicked down the road again. So now we are at a September 30th cliff, which is when the budget bill or the continuing resolution is set to expire. So what is likely to happen because of the turmoil in Congress right now is that we are anticipating it might actually fall off the cliff unless Congress takes action between now and September 30th. Um, it's becoming more and more likely that we're going to hit that cliff because Congress is not functioning well right now. There are just so many competing priorities, and so much with the budget that is being contentious. So the The least likely scenario is that Congress will act and pass. There are so many pieces of legislation right now that would make this permanent. So the least likely scenario is that they'll actually take the time to pass that bill and make all these things permanent. The most likely scenario is that it will get attached to a continuing resolution, but the continuing resolution might not pass for a little while after government shuts down. And that's what we're all kind of bracing ourselves for at the moment. What would happen in the interim? CMS has basically said we're not going to go backwards and grandfather in anything that happens during that break. So we know that if we fall off the cliff and whether there's a 1 week, 2 week, 3 month, who knows how long that's going to take, for them to pass some kind of either short-term or long-term solution, we will revert back to pre-pandemic Medicare guidance, except for the things that have been made permanent already. So what does that mean? And unless Amy joins, I can go into detail about this if that would help you guys.
Yeah, I
So,
would actually.
okay. So what that means is patients will not be able to have telehealth services to the home because pre-pandemic home was not an eligible originating site. The things that have been made permanent are mental health, substance abuse services. So if you're providing behavioral health, mental health, or co-occurring conditions, that is still eligible to the home. But CMS has also instituted an in-person requirement, and that happened during the pandemic, but it was part of the waiver. So what that language said was that in order to do telemental health services to the home, there had to have been an in-person visit within 6 months of the telehealth visit, and then annually thereafter. Since it's never been implemented, we have no guidance on what that means, whether existing patients would get grandfathered in. And so to avoid that 6 month prior thing, because, obviously nobody was seeing people in person 6 months prior if they were all telehealth. We have had so many providers, mental health providers, who have flipped to all virtual, who don't even have actual offices. And then for our rural patients, sometimes the people that they're seeing are hours and hours away or even in the next state. So we're still waiting on some guidance from CMS on what would happen if we hit the cliff and they reinstitute that in-person requirement. So we're kind of wait and see mode for that. The other two things that they have there's Amy, they have grandfathered in is for people awaiting or for people needing stroke or neurology assessments. They have made teleneurology, telestroke available to the home. And then those with kidney failure who need ESRD services, that is eligible to the home. But those are the only three services that they have said yes to the home if we fall off the cliff. And maybe I'll let Amy jump in and do her part, and then I can come back to the Medicare cliff piece, because I know Amy's like bouncing between clinics.
Yes, I am so sorry for logging in late, guys. But for those of you that I don't know, I'm Aimee Strong. I'm the nurse practitioner here at UVA. And I run our lung cancer screening program and also work in thoracic surgery, which is a nice blend of cancer screening and then cancer interventions. But just wanted to tell you guys a little bit about our telehealth program that we've developed here, and kind of to give you some historic background. In about 2015 or 2016, we received a grant from the Virginia Commission on Tobacco Control, and we were able to use that funding to identify a couple different health or hospitals within a very rural environment that weren't tied in with big medical centers, that didn't have a lot of resources. And we were able to partner with a very small little independent hospital down in Grundy, Virginia, which is kind of in the southwest corner of Virginia, very near Kentucky and Tennessee. This health or hospital didn't have on-site radiologists. They had really limited access to big medical centers. They had some providers that were available, but given the rural nature of that area, they had a lot of provider turnover. So we thought this would be a great opportunity to partner with this hospital for lung cancer screening, which back then was still kind of new, and everyone was just learning how to implement lung cancer screening. So we came up with a telehealth program, which was a really nice solution. Basically, those providers would identify patients in their area that might be eligible for screening. They referred them to our telehealth program, and then myself, as the advanced practice provider, would meet with that patient when they were in person at Buchanan General Hospital through our, back in the day, new telehealth system. I would have the shared decision-making conversation with that patient, initiate some smoking cessation counseling, and they would get their scan right there at Buchanan General. Those scans would get sent up here to UVA, and our radiologist would read those scans. And then those became my telehealth patients, and I would follow them longitudinally for their yearly screening and help that would facilitate any follow-up scans that needed to be done or any referrals in their local region. So we did that for several years. And what we found is that it was kind of hard to get those patients. The telehealth portion worked great. The patients loved it. It was super easy. It was a one visit for them. But we found that it was a bit of a barrier too, because it was hard to get those patients on the phone to schedule the telehealth appointments. We were a foreign area code back then, so patients were a little hesitant to answer a number that they didn't know. And then the referring providers felt like they were referring these patients to us, but then there was this big delay in getting them to screening. So that became kind of a project for us to work on. And then fortunately, we were able about 2 years ago to participate with the ACCC on a lung cancer screening project in rural Appalachia. And what we did with this is we identified the barriers that we had within our own telehealth program, and we were able to use the funding to support education for the local providers, with the philosophy that maybe if we could get these providers a little more familiar with lung cancer screening, give them the tools to do it themselves, that might make it easier for them to get their patients into lung cancer screening. So we spent the better part of 2023 and early 2024 doing a lot of provider outreach. And we did this through webinars very similar to what we're on now, where I've met with local providers in that region to educate them on lung cancer screening, how to perform the shared decision-making visit, how to bill appropriately for that, how to order the right CT. And then they could meet their patients in the office during their regular visits, talk to them about lung cancer screening, have that shared decision-making conversation, and then send them to Buchanan General Hospital for their scan. Those images still got sent up to us through our teleradiology program in red here at UVA. And then behind the scenes, our lung cancer screening team was looking at those results and partnering with those local providers to help get the patients to the next steps, whatever that might be. So it turned out to be a really great way to use our original telehealth program and really expand it out and empower local providers on lung cancer screening. Since doing that, we've seen our numbers just dramatically jump. Where we were seeing maybe 10 or 12 patients a year for lung cancer screening. I think we're already up to like 50 or 60 patients just in the last year, which for this tiny little area is a lot of patients. So we've been able to really just evolve our lung cancer screening program through telehealth. And also use telehealth to really reach out to providers and give them the tools to do this themselves. And we've had a lot of great success with it, and really learned a lot, because what we found, again, is that people want to get lung cancer screening. They don't have great access to care. And that we can use some of our tools to get more patients in for screening, but also decrease some of those barriers in some of these rural populations. That's kind of our telehealth program in a really small little nutshell. But one thing that we have also done as part of the evolution of our lung cancer screening program is that aside from this telehealth program that we have in rural Southwest Virginia, I also have a lung cancer screening clinic here at UVA where every Monday I see people for shared decision making. And a couple years ago, I transitioned that to 100% telehealth. So for our Medicare patients, we're allowed to do an audio only shared decision making visit. The code that we use for that is G0296. Medicare made that a permanent telehealth code. And, you know, as you guys know, the telehealth laws are constantly changing, and we're waiting to see what's going to happen in this congressional session with telehealth laws. But Medicare did make shared decision making for lung cancer screening a permanent telehealth code and audio only. So I have several patients every Monday where I'm doing shared decision making via phone. And then for all of our commercially insured patients, including our Virginia Medicaid, I do a live audio-visual telehealth visit for those patients. So we're able to have people in their home at their convenience, have a visit with me to talk about lung cancer screening, and then we set up their scan for some time after that. So that's really been a big patient satisfier. It spares people having to come make a separate office visit to see me for lung cancer screening, and has worked out really well. I think our patient satisfaction for that telehealth portion of lung cancer screening is pretty high. But lung cancer screening, the shared decision-making component, is reimbursable. So I bill for those visits. There is a specific billing code that goes for that. It doesn't generate a lot of revenue, but it's, you know, everything's kind of RVU based. And I think the reimbursement for lung cancer screening, shared decision making is like a quarter of an RVU. So it's not a lot, but it is something that's billable. That shared decision making component's covered at 100% through Medicare, Medicaid, and all insurance plans that are available on the marketplace under the Affordable Care Act. So the conversation with me, whether it's telehealth, audiovisual, phone, or if I'm doing it in person, is covered at 100%, as well as that baseline and annual scan. And so we do spend a lot of time with our providers, letting them know they can bill for that time that it takes to do the shared decision making. And we should kind of show them the billing codes on how to do that.
As I mentioned prior to this, that, you know, to the home, if we fall off the cliff, the to the home piece would be out as an eligible site of service, except for those couple exceptions. Audio only would also become a problem because the way that they made audio only, they actually made audio only permanent, but the way that they put the language in was it's permanent to the home if the provider has access to video and the patient refuses to use video or cannot use video because of broadband or whatever. But since telehealth to the home has not been made permanent. If we hit the cliff, telehealth to the home is not an option. So that's the little quandary that we're in. So if telehealth to the home makes permanent, then audio only is also made permanent to the home, which is a really good place to be, but we're not there yet. So that is the one piece. The other pre-pandemic piece that y'all probably need to understand is that you can still do telehealth, but the patient needs to be in a eligible facility in an eligible geographic area. What does that mean? Pre-pandemic, that meant that the patient would need to go to an actual healthcare facility. So home obviously was not an eligible healthcare facility. So a clinic, an FQHC, let's say, or another, you know, physician's office, those are eligible facilities. So what happened pre-pandemic was that, like, let's say I'm in Charlottesville and I'm seeing a patient in wherever, 2 hours away, I would contract with, let's say an FQHC there to say, hey, can you serve as an originating site for my patients so that they can go to your facility, get the telehealth visit from me, from your facility. You can bill for what's called the facility fee or originating site fee, which is about $25 just for their time and service for hosting the patient at their site, and then the provider would bill the professional fee. That was what used to happen. And then, of course, when it opened up to the home, it just transformed everything. So if we go back to pre-pandemic Medicare, you're going to have to work that out. On top of that, the facility has to be located in a rural and underserved area. So their definition of rural is not outside of an MSA, metropolitan service area. Um, if you are in a metropolitan service area and still considered rural, like you look outside, you see cornfields, then you also have to be considered rural by the Office of Rural Health Policy definition and designated as a HIPSA, so a health professional shortage area. So that it just gets complicated. If you go to our website, and I can also put in a preparing for the policy cliff thing that we've developed at the National Consortium of Telehealth Resource Center. I'll put that in the chat there so you can kind of get all the nitty-gritty details of that. But we created kind of a blog site to point you to the documents that talk about the changes if we hit the policy cliff, and all the kind of contingency planning and communications planning that you should probably be working on now, because we are likely going to hit that cliff in the next 2.5 weeks. But those are the big changes.
The question in the chat, I was just going to address from Callie, who says she's a respiratory therapist. Can she document the shared decision-making visit via telehealth co-signed by a pulmonologist for screening? Which, I mean, there are some ways to do that. You are allowed, providers are allowed to delegate the shared decision-making conversation to an appropriately trained person, and you as a respiratory therapist, Callie, would be appropriate for that. And then that shared decision-making, if you wanted to bill it, could be billed incident to the visit with the pulmonologist, but you have to make sure that your facility and setup is allowed to do incident to billing. And I can tell you, as at UVA, we don't do incident to billing, so we haven't taken on this model, but I think there is a pathway to do that.
Is there anything that we can do advocacy wise to maybe help?
I think the best thing is to continue to write letters, call, email your representative, your congressional delegation, and just mention how important it is to continue the waivers or to make them permanent, ideally, because of the impact that it will have on your patients.
Yeah, I can't agree more, Kathy, with how important it is that we have our voices be heard. I think that, telehealth has been such an important addition to healthcare in general, not just in the lung cancer screening world, but in healthcare in general. I can't imagine going backwards in time to how it was pre-pandemic with these telehealth laws. So if all of us reach out to our delegates and representatives, it's so important because I do think it makes a big difference.
Yeah, and right now there is huge bipartisan support for telehealth, so that is really not the issue. It's more the attention of other competing things going on in Congress, and that they may or may not get to this until the other things are resolved. So that's the issue. But I think if we keep it on their radar screen how important it is, maybe somebody will go, oh yeah, we also need to before September 30th.
Well, that is very helpful. And I think we all have homework now to contact our legislators. But thank you for joining.